So let's see. I'm Angelica Sadar. Nice to have you here. Um, Before we begin with tonight's webinar, I just want to make a few announcements. The main one is that the NRBS conference is going to be in New York City this year, October 24th through 26th. Rethinking Paradigms, Innovative Approaches for Optimal Wellness. We have a really good bunch of presenters that include both Bessel van der Kolk and Thomas Campbell, both New York Times bestselling authors. Lots of other things going on. If you haven't been to New York City, this is your chance. We are going to make it fun. The hotel's fun. The events are fun. The location is fun. So take a look at that. We'll put the link in the chat. And then I also want to remind you all of our podcasts. Dr. Saul Rosenthal is the leader of that. He's got a whole new series that's going to be airing as the conference approaches. And for your history buffs, we're also releasing a series of podcasts by past NRBS presidents that will be coming out shortly. Y'all should know by now about the first Tuesdays of the month are times to chat, meet with other professionals. I think that kind of covers everything. If I forgot something, somebody jump in, please. Tonight's webinar is brought to you by Biomedical Instruments. They are a longtime supporter of NRBS. They provide equipment, including hardware, software, training, technical support, and so much more. I really encourage you to support them as they have supported NRBS through the many years and are really good supporters of the entire field. And then I want to introduce our speaker, Santiago Brand. He is the founder and director of Mind Lab Neuroscience Consulting in Singapore. He's a clinical and sports psychologist, board certified in QEEG, brain mapping, biofeedback, neurofeedback. He's got it all. He's an educational instructor in Mind Out centers and a faculty member at the Learn from the Best program of the Biofeedback Federation of Europe. He's a scientific advisor for iMedisync. He's got 15 years experience working with sports and peak performance. He's lectured in over 20 countries, but now the important things. He's a caring person. He's a wonderful teacher and just an all-around nice guy. So please, let's welcome him. He's going to talk with us about neurofeedback in children. Thank you, Santiago. Nice to have you.
Thank you, Angie. Thank you for the kind words. And good morning, everybody from rainy Singapore. We woke up with a huge thunderstorm here, so you might hear a couple of booms here. The lightning and the thunder are quite loud today. And I'm very excited to be here to talk about this because it's a topic that I'm passionate about when it comes to working with children and specifically working with the EEG, the QEEG, and the neurofeedback for a much more profound understanding of the brain and to also transform mental health care. One of my purposes when I do these lectures and when I do QEEGs for clients and when I go talk to schools and talk to parents and talk to teachers, it's to emphasize the importance of QEEG and through case studies demonstrate why we think it's a wonderful tool. And for those of you who are here today, I'm going to emphasize more the QEEG part of it. I'll talk about the neurofeedback. There's a couple of PowerPoint slides that mention the DSM, but I'm not going to spend too much time there. I want to emphasize some case studies of my own that I found interesting, quite fascinating cases. And again, to highlight the importance of why QEEG is the gold standard assessment tool, at least one of them, and then why neurofeedback should be standard practice in terms of brain training or performance optimization and better, more robust mental health care. Now, I agree with Angie. She was saying just a few minutes ago, how do we get this in schools? My take on this for quite some time has been QEE should be part of every school, every doctor's practice. It should be as standard as getting an EKG, as getting a mammogram, as getting your prostate exam. It should be quite standard practice, and it should be in every psychologist's office, doctor's office, school. And if it were, I think we would have a healthier, happier society. When we start working with children, we prevent the dysfunctional adults. And that's at least my experience. Now, without further ado, I think we should get started in the interest of time. So we have some learning objectives as usual. And the first one is to learn how QEG is, again, in my opinion, the gold standard assessment. How neurofeedback can also help optimize brain activity and mitigate symptoms, eliminate symptoms for different conditions, and also how we should talk about working in collaboration with different sets of professions: medical doctors, psychiatrists, neurologists, nutritionists, but more importantly, those people who are more involved on a day-to-day basis with the children, which are the teachers, the parents, the caregivers, etc., etc. So hopefully, once you get this info, you can spread the word. Talk to teachers at their local school board, talk to other professionals, child psychiatrists, pediatricians, psychologists, and help them understand why they might want to include QEG as part of the assessment, as part of an assessment tool, and then also why they might want to include neurofeedback for the intervention. Now, again, we're going to start with the DSM, and I think it's important to talk about it because this is what's most commonly used for assessments and quote unquote diagnostics. At least in my experience here in Singapore and traveling around the world, is that most people are diagnosed through the DSM. And interestingly enough, quite a large number of people now, especially those, tell me that they self diagnose themselves um, through different means. Some of them will tell me, I know I'm autistic. I know I have ADHD. I know I'm a mixture of the both. I have self-diagnosed myself. To which I will say, okay, let's take a look at your brain and let's see what the brain has to say. Now, I think DSM criteria is important. I'm not here to discredit it altogether, but one of my biggest beefs with DSM criteria is that you will always see an overlapping of symptoms no matter who you assess. If we were to assess everyone here in this meeting today, the 40 plus people that are here today, then, and if we go through the DSM criteria, we're probably going to have symptoms of a lot of conditions. We're going to meet criteria for a lot of things because it's essentially checking boxes. Now, some of that might apply, some of that might be true, but beyond that, we need to understand why it is happening and where it is happening. So, what I normally tell people is, okay, let's say that you do have ADHD. Let's say that your child does truly have ADHD. Let's see how that is manifesting in their brain. That's the most important thing. And when we look at the cases in a moment, I will specify why is that, what that is important. Some of the diagnostic criteria for ADHD is difficulty maintaining attention, failing to follow instructions, get easily distracted. Yes, those are common traits and behaviors that we will observe in ADHD children or people who meet the criteria for that. And then there's a criteria for being hyperactive impulsive, which is being restless, an inability to engage in activities, particularly activities that require concentration for long periods of time, excessive talking, and difficulty waiting for their turn. Fine. Let's be fair. These are traits that you have observed, I have observed in children who are ADHD when they come for the brain math. You put the cap on, they try to take it off. You tell them sit still, they don't sit still. You ask them to close their eyes and they open the eyes. Yes, we see this, but we need to go beyond this because again, if we go by this criteria and we just check boxes, most of us would meet the criteria for ADHD without it necessarily meaning that we are ADHD. Now, the same thing goes. There's a time frame here to diagnose this. So, if the symptoms are present for at least 6 months, then we need to go do further assessments. Okay, and one of the things that they highlight here is functional impairment, which I think it's in the eye of the beholder. Of course, we know the general construct, but it's important to understand how that concept needs to be individualized, how it manifests for a particular individual. The symptom onset, meaning the symptoms start before the age of 12, and they have to be present in two or more settings, meaning home, school, work, or maybe all of the above. Again, all of these criteria make sense, but it doesn't go in depth. And that's my biggest problem with this, that it shows that somebody might have ADHD. But as we will see very soon, it manifests differently for different individuals, depending on the age, depending on the gender, depending on their background, depending on their genetics, depending on their metabolism. And therefore, what's very important here is, in addition to this, we need to see how it is manifesting in the individual's brain. Now, the same case goes for autism. So the DSM now has some criteria that they have listed for autism, which are deficits in social and emotional reciprocity, difficulty with nonverbal communication, challenges in developing and maintaining relationships. So all of these are clear-cut behaviors that you can visually observe in the autistic individual when they come for the assessment. Just by interacting with them for a couple of minutes, you can get an idea that they are going to check a lot of these boxes. And that's fine. We have an initial construct, an initial idea of how things are, but is not enough, in my opinion. And again, there's a time frame criteria for the diagnostics. So in all fairness, it's not like we're just checking boxes. We have to make sure that this has been happening for a specific period of time, that it has been occurring under specific conditions, in specific settings, under a specific set of circumstances. And that's the takeaway from this. Now, let's talk about what we're here to talk about, which is the emerging approaches, more specifically EEG, QEEG, and neurofeedback. Now, the QEEG, as we all know, the technical term is quantitative electroencephalography. Some of us like to call it a brain scan or a brain map, just to take away the fancy clinical jargon and to make it more attractive from a marketing perspective. When I say QEEG, people look at me funny, but when I say let's do a brain map, let's get a brain scan, that gets people attention. And then they ask more questions, and then I will explain what that means, what that entails, and I will use a couple of technical terms just to get them to understand the main idea here. Now, what do I like about QEEG? Well, it's evidence-based, it's data-based, and it also measures brainwave activity. It helps us find dysregulation in the brain, specific patterns of activity that should not be happening in specific regions of the brain. So instead of checking boxes, now we will know specifically where in the brain the problem is. What dysregulation is it? Where is it coming from? What is likely causing it? And then what we can do to stabilize and optimize that brain so the person can function more efficiently. We identify patterns. If you know anything about my work, is that I don't like labels. I do my very best and I try my hardest not to label people. So when people come and I do the EEG, I will talk about patterns and tendencies. I say, your child has a tendency to lose attention at specific times. Their brain has a tendency to get tired. Their sleep needs some fine tuning. And most people are okay with that. There's a percentage of people who will push me and try to corner me into providing them with a label. Sometimes I will, just to appease them. But if I can help it, I will talk about patterns and tendencies, because that we can correct, that we can fix, that we can stabilize and optimize. I find sometimes that providing somebody with a label is like giving an actor a character and they're going to go method. Throughout the shooting of the film, they're going to remain in character. And sometimes that's what people do with the labels. Oh, I'm ADHD, therefore that's why I do this. Oh, I'm autistic, therefore this is why I behave this way. And sometimes people use this as an excuse, and they becomes part of their personality. Therefore, I prefer to use the approach which talks about tendencies and patterns, and I will relate that to you as we look at the EEGs. Now, we also have neurofeedback brain training. And this modality for brain training has been around for a while. The good news is the technology has gotten better. Our ability to look and understand the brain has gotten better. And we are now able to train professionals more efficiently to work more responsibly and ethically. Now, when we do neurofeedback, we do it in conjunction with other neuromodulation strategies. And that means that we use technology, non-invasive technology, that is, to help train that brain. When we do neurofeedback, we know that we train the brain to mitigate symptoms, to eliminate symptoms, hopefully mitigate medication, hopefully eliminate medication, and to optimize and stabilize brainwave patterns, which will bring about certain positive changes in that person's life. From flunking out of school to becoming a straight student, from forgetting things to having healthier memory, from being a very angry, aggressive person to being more self regulated. Whatever it is that we want to do, if it is within our reach, we can target that and we can change a person's life literally. So we use this in combination, and then we also work holistically with other professionals. If medication is needed, we talk to the neurologist, we talk to the psychiatrist. If a nutritional assessment is needed, then we refer to a nutritionist. If we need medical assessments, we talk to a functional medicine doctor. Our field has facilitated bridging the gap among professions, the way I see it. And I think that's a huge gain in our industry, and it's also a huge gain for society in terms of better health and better physical and mental well-being. Now, I've already explained what QEEG is, and so there's different ways of recording the data. Um, what we're doing is assessing brain function. Again, we're looking at the brain and we look for patterns. When the brain speaks to us, it speaks in patterns. That means that specific brainwave activity will show up repeatedly, and we pay close attention to it because this brainwave activity may be problematic. In the eyes open recording, if we're seeing excess slow waves in certain areas of the brain and they're happening repeatedly, we pay close attention to that. If we see spike in wave patterns, we pay close attention to that. If we see transients, we pay close attention to that. So it's about setting a dialogue to the brain. The way I always explain this to the client is we are going to talk to your brain. We're going to see what your brain has to say. The one thing that I do, and I think most of you do out there, is I don't ask the client for any information on their symptoms when I do the QEG. Okay? I go literally blind on the information and I let the brain do the talking. So then I relay the info to the client and they tell me yes or no, and they tell me how much they think that really relates to them. And I think that's one of the biggest added values of QEG, that we can actually tell the client a lot about themselves without knowing them and meeting them for the first time. So let's talk about some cases. This is some research. Research is important. So I'll be happy to share these papers if you're interested in reading more, because I want to focus a little bit more on the EEGs in the interest of learning and time. Dr. Swatina, out of Houston, it's one of the biggest contributors to our industry in terms of research. She's one of the biggest and strongest researchers out there, and he has contributed quite largely to our field and the growth of the field in terms of understanding EEG and brain training. So some of this I'll talk about. I'll show you a couple of ADHD cases. I'll show you a couple of sleep disorder cases, and I have a case of suicidal ideation that is going to be quite interesting, I hope. So let's talk about cases then. All right. Here's what we have. Let's start with ADHD. Again, people come diagnosed with ADHD because they have a formal diagnosis by a mental health professional. Or sometimes, people will tell me, "Oh, I spoke with a friend of mine and her child's ADHD, and his symptoms match my child's symptoms. So I think that he's ADHD. Or they read a paper on a magazine and they had a list of the symptoms and they checked 4 out of 5, I have ADHD. So people come with formal diagnosis. Many times people will come to me having self-diagnosed themselves. And I don't challenge that anymore. I will say, let's see your brain and let's see if it matches your perception of your symptoms. Now, here's one case there. And here we have the EEG. That's the first thing that we record. We'll see all the squiggly lines that go up and down. Some of them are big, some of them are small. And as I always say when I teach, the very first thing we need to do is to record a clean EEG. If you remember the movie Fight Club with Ed Norton and Brad Pitt, and you remember the rules of Fight Club, rule number 1 is we don't talk about Fight Club. Rule number 2 is we do not talk about Fight Club. And when I teach in the EEG world, what I will say is there's 2 rules to the EEG. Rule number 1, always record a clean EEG. Rule number 2, always record a clean EEG. Okay, without a clean EEG, it doesn't matter what system you use, it's not going to be useful for interpretation. If you're recording a crappy, noisy EEG, you're not doing this job responsibly and ethically. Now, what I will do is I will focus on this and I will refer back to the slides just to show the patterns that you can see for ADHD suicidal ideation. But the reason I flew by on the slides is that I want to show this and then go back to the data so that we can correlate this information. No worries. And then, of course, we'll get a recording of that. So I'll go back and do it. Now, what we have here is the EEG. Now, if the person doesn't understand the EEG, I'll go to the maps. The next thing I go to the maps. And I explain to them, okay, look at this map. And this is what the colors mean. And this is what the activity in the maps mean. And this is the brain region that's impacted. And these are the brain regions that we need to fine tune. Okay. The client doesn't care much about the EEG. They're more captivated by the maps, the 3D renderings, and so on and so forth. But our job as clinicians is to understand the EEG. I don't care how much experience you have. I don't care what system you use. If you're a clinician and you're not looking at the EEG, you're not doing this ethically and responsibly. And I say that because I've been fortunate enough to be around 26 countries now, working with consulting with businesses and clinics. Many times I go and they start showing me the set of maps. The first thing they show me is this, what you see in front of you. And they start showing me the maps and I will say, okay, that's fine. Now show me the EEG. And when they go back to the EEG, it's all full of noise. So many practices are sadly interpreting information and they're providing info to their patients, to their clients out of contaminated EEGs, false positives in the back. Now, here is such a case. This is a clean EEG. And at 54 seconds, we can see a burst of what looks like theta waves. We can count them here. 1, 2, 3, 4, 5, 6. So it looks like we have 6 hertz theta at the front. And here we have some activity coming out of the midline FZ, F4. And then we also look at a burst of huge theta waves, 1, 2, 3, 4, 5, coming out of the back. So in this EEG, this is just a snapshot, but the pattern is quite continuous. Okay. And so here we see a slow EEG. And now we can go to the QEEG, to the maps, and confidently say, yep, you have a lot of slowing back here. So this kiddo was diagnosed with ADHD. Okay, now let's see how the ADHD, how the symptoms and how the behaviors are manifesting from the neurophysiological perspective. And what do we see? Well, we see there is some high amplitude theta at FZ. And one of the things that correlates with is what? It's oppositional defiant behaviors. Is that common in ADHD? Yes. We have slowing in the parietal region that impacts sensory processing, perceptual processing, learning, consolidation and acquisition, memory consolidation and acquisition. So now we're seeing how that ADHD is manifesting. For this case in particular, these are the brain regions that we need to target, and these are the frequencies that we need to target. Okay. Now, if we go back then to the data, the research. Let me go back here. So common EEG findings, and let me just make this full screen, sorry. Common EEG findings include elevated theta waves. We saw that in the case that we just examined. Okay. Associated with poor cognitive performance. Yeah, but what elements of the cognitive performance is that impacted? Sensory perceptual processing, attention, and so on and so forth. Some of those have found IEDs, interictal epileptiform discharges. And I'll show you an EEG now that has those. Okay. Again, 3 or 4 kids diagnosed with ADHD, different brainwave patterns, different brain regions that are compromised. Okay. Now, what Dr. Swatina has found is that there is abnormal connectivity between brain regions. So that may be problems with coherence and connectivity, meaning how are brain regions talking to each other? Are they not talking to each other efficiently, or are they hyper communicated? Are they talking too much? And the only way we can see it is through the EEG and the QEEG. We cannot see it in an interview. We cannot see it in a behavioral observation. We cannot see it through paper and pencil testing. The only way is looking directly at the brain. And that's very important because, again, we check symptoms, yes, but we don't know what is happening in the brain. And there's also a high prevalence of sleep disorders in ADHD, autism, and other conditions present in school-aged children. So we now need to understand that looking at sleep architecture is very, very important. Suicidal ideation is a problem that's growing. Here in Singapore, the age range that commits most suicides is from the age of 19 to 24. So it's school freshmen to college graduates, college first college graduates. That's the demographic that has the highest suicide rate in Singapore. Now a lot of the focus is driven towards that. And I'll show you a case of a 16-year-old girl that I saw here in Singapore a couple of years back that was presented with suicidal ideation. So again, as you can see, there's a comorbidity and a mixture of symptoms that are present, and we, as a consequence, as a byproduct, we have the overt behavior presentation. OCD is also present. So the theta that we just saw for this case here at FZ could represent OCD. One of the first things that I suspect when I see elevated theta is either oppositional defined behaviors, OCD, or maybe OCD traits. So as I describe this to the client, now they will tell me, yes, that sounds like me. No, that doesn't sound like me. I did an EEG for a 12-year-old girl yesterday, and she showed up with the theta here. And the father was present, and the father said, I think that's my OCD that I passed on to her. The father's OCD, the girl presents with oppositional defined, it's a teenager, but she also presents with OCD traits. So now we can see that it's an inheritance, genetic, epigenetic pattern. So here are the set of maps coming from this EEG. And that helps us understand where we need to work. So we have excess delta waves in the back, excess theta waves, and then some excess alpha waves, particularly in the slow alpha range. For this child, the most problematic region are the parietal and occipital lobes. So part of the hubs of that default mode network. We also see some frontal impact that needs to be addressed as well. We would have known this. We wouldn't have known this if we hadn't looked at the EEG and then from there go to the QEEG. And that's our first ADHD case. So do we have slowing and theta waves? Yeah. We have some beta present as well, but the salient presentation here is that theta pattern. Now, here we have another ADHD case. If we go by the traditional standards, then we would think and we would assume that this brain is going to look the same. Okay. We don't need to look at them because all ADHD cases are the same. Well, let's see if that's the case. So here, if you look at PZ, you can see that there's this spiky pattern, and you can also pick it up here at C4. So this is the IEDs. Let me go back to that slide. Those are the interictal epileptiform discharges. Here we go. IEDs, interictal epileptiform discharges. 40 to 45% of those individuals at any age range diagnosed with ADHD will have IEDs, interictal epileptiform discharges, in their EEG. They're quite common, is a quite common pattern in ADHD children. And we see it in this EEG. This is the EEG of a 6-year-old that I saw many years back, presented with ADHD behaviors, mostly with a hyperactive tendency. This is a very hyperactive child. And upon seeing this, we can pick up the IEDs. I did an EEG yesterday of a 5-year-old, and he had the 5-year-old diagnosed with autism, and he had the same pattern in the EEG. It was just a replica, carbon copy of this EEG, the same spiky IED being broadcast from the parietal region. So as you can see, we have one ADHD case with slow content, and now we have the IEDs. And what's important to understand here is that epileptiform activity doesn't equate epilepsy. It means that we're having a discharge in the brain, but it's not strong enough to cause a seizure, a convulsion, an actual physical seizure of convulsion. It's just strong enough to create problems in this region. So we're going to have sensory processing, perceptual processing, language difficulties, learning difficulties, working memory difficulties. Now, in addition, for this case, if you notice, the other pattern that we need to pay attention to is that we have very slow background rhythm. So now we need to start looking at the alpha trend for this child. Okay. So here we are providing an interpretation for the person, and we can see that there's low background. So now we need to see that we have to look at that alpha trend, and let's go ahead and do that through the QEEG. From the EEG, once we record a clean EEG, remember the 2 rules. Rule number 1, we record the clean EEG. Rule number 2, always record a clean EEG. Now we can go into the QEEG portion of that. You can see here at PZ that elevated theta peak, which correlates with the IET. So this is your generator right here. And if you see, his alpha is very slow. The theta is now creeping into the alpha range. And his alpha peak frequency is 7.08. It's not even the alpha range. So what is this compromising? Well, one of the general constructs that this is going to compromise is intelligence, brain processing speed, connectivity. It's very slow. And what this discharge is causing is the interruption of perceptual processing, sensory processing, language, behavior regulation, because this kid was extremely hyperactive when we started working. And then as you can see, we have 2 ADHD cases. This kid is also 6 years old. Coincidentally, this child was this child's classmate. Same school, same classroom. They didn't know that we were seeing each other. It was just a coincidence when the school referred them to me. And as we can see, both kids diagnosed with the same condition, yet we see different brainwave patterns. This one needs work on the peak alpha frequency, because this kiddo, his peak alpha frequency is around 9.7, which is quite robust for the age and probably likely to develop into a healthy alpha pattern what we need to do is to suppress the slow pattern here. Now, and again, this is the distribution of the activity for the IED. So this is just where the general area is and the regions that it's impacting. You can also see that it's impacting the parietal region. It's just that the impact comes from a different discharge. And what's risky about this is that many times the parents will go to the medical doctor saying he's extremely hyperactive and he's very likely to be prescribed with an stimulant, Vyvanse or Ritalin or something of the kind. And if we have this type of activity here, the risk that we know we run is that we can make this even worse if we supplement, if we dispense a stimulant for it. So now I'm not a medical doctor, and I wouldn't even call it epileptiform. I would say I have a pattern here that I'm finding interesting. What I'm going to do is I'm going to refer you to a neurologist friend of mine, and they're going to tell you whether I'm right or wrong. And if I'm right, they're going to tell you exactly what this is and what you need to do. And the neurologist will say, yep, Santiago is right. This is called IEDs, and they're epileptiform. They don't mean epilepsy. And we think your child will benefit from an anticonvulsant. And this is the anticonvulsant that we think will help him. Then we'll start with neurofeedback and we'll work to titrate the medication and down the line, eliminate the medication. Okay, I don't diagnose it. I don't call it because I know that depending where you are, you cannot use the word diagnostic, so you cannot use medical terms. So I talk about patterns and I make the referrals. And most of the referrals I make when I have activity like this will go to Rusty Turner in South Carolina. I think most of you know Rusty. Very lovely individual, very smart epileptologist. And he will talk to the parents, he will make the consult with the parents, and he will provide them with additional information. And so here are the maps distribution. But remember, the most important thing is that they came from a clean EEG. Without a clean EEG from there on, you only have fake data. This is another ADHD case. This is an 11-year-old that was brought to me by the mom. The mom is a counselor here in Singapore, a good friend of mine. And he was brought because he got in trouble at school. This EEG I recorded maybe 3-4 years ago. He was at recess. He was walking around the playground. And he saw a whiteboard, small whiteboard that one of the teachers left on the ground. And he decided to pick it up and just throw it frisbee across the playground. So the thing flew and it ended up hitting another child on the right eyebrow, and the child ended up getting stitches. The parents of the child who got hurt filed a police report. So the police was called, they did an investigation, and the school said, you have to have some kind of assessment for your son, otherwise we have to expel him. So she brought him to me, and we decided to do the EEG. What I'm going to show you here is the eyes closed EEG. I don't show you the eyes open because the eyes closed shows the type of activity that I want to emphasize. Now, as you can see, at 46 seconds, we already have the infamous vertex wave. So we have stage 2 activity, but we have a vertex wave, which means at 46 seconds, this kiddo, it's already either very drowsy or very likely falling asleep. And if you have a vertex wave before the 300-second mark, when I record EEGs, I do 10 minutes of EEG with the eyes open, 10 minutes of EEG with the eyes closed. If you get a vertex wave anytime before 300 seconds or the first 5 minutes, it's very likely that this person has a sleep disorder. And if we go back to our slides here, these researchers have found that in both ADHD and autism, we have altered, dysregulated sleep architecture. And it happens more often than we want to think. So now here is the case for an apparent, and I say apparent ADHD because in reality, we're dealing with a sleep disorder. And as I'm talking to the boy and I'm talking to the mom, I'm saying I'm looking at the boy and saying, this is one of the reasons why you're falling asleep in class. And the mom reacted saying, he doesn't fall asleep in class. And he turned around and said, yes, mom, I fall asleep in class. So the mom got upset and she said, how come you never told me? And I said, look, let's not fight. Let's find what the problem is. So I refer them for a sleep study. Every time I see this and I see that there's a high probability for sleep disturbances or sleep disorder, I send them for a sleep study. The vertex wave indicates, for the most part, three possibilities. Number one, sleep apnea. Number two, narcolepsy. Number three, probably a parasomnia of some kind. But again, I'm not a medical doctor, so I will say this would indicate problems with sleep. My suggestion is that you get a sleep study. And they did get a sleep study, and they didn't find anything quite wrong with obstructive apnea, but the doctor did some additional testing, and what they found is that he had an allergy. The mom was using this spray scent things for the home to smell better, and he turned out to be allergic. He had one in his bedroom, and the thing was on through the night when he was sleeping, and it turned out that he was allergic to. So once they took that out, the the allergy went away, and the sleep started getting better. In addition to doing the neurofeedback for it, and when I look at sleep problems at any age, particularly with children, I will ask the parents, when you went to the psychiatrist, when you got your diagnostics, did they look at their sleep? And the number of times that these professionals have looked at sleep is zero. Parents always tell me, no, they never ask how he sleeps. They just ask a few questions and they prescribe the medication. So now we can also see the case for sleep disorders being present. And this happens across ages. I've recorded EEGs of 6-year-olds who have been diagnosed with sleep apnea, 5-year-olds, and not necessarily obese or overweight kids. These are fit kids who exercise, who do sports, yet they present with sleep difficulties and disorders. And here you can see the SW Lorera assessment for that. So you can see the distribution for it. The QEEG helps us see where the brain is impacted and how we can help that brain. And you can actually see the spectra for that. Now, in this kid's defense, he's making some solid alpha, some robust alpha. So at least he has that, but the vertex pattern indicating the sleep disorder is not helping at all. Now, this is autism case. And here we can see that there are several patterns. For one, this kid's presenting with mu waves over the right sensory-motor area. He's got an elevated alpha peak at P8 with some elevated beta, which may indicate the possibility of an Asperger's presentation. It's a common pattern to see mu brain waves, the elevated beta, the elevated alpha over the right temporal parietal region that correlates with autism. And we can see elevated fast beta waves as well. So this is one of the common hallmarks and neuromarkers of autism. The kid presents with autistic behaviors, autistic traits. And here you can pick up some of the mu at C3, and here you can pick up some of the mu at C4, some transients here, some sharp transients over P7. These are all the patterns that we look for that we then identify through the QEEG. And that helps us understand the brain more specifically. Here we have a Loretta composite of this brainwave activity that shows that we have an active, overactive anterior cingulate indicating oppositional defined behaviors. And we have the left and right insular region being affected, which indicates a more sensitive, a more aggressive, more angrier person. Now we can correlate the EEG to the specific brain region, and that helps us understand the symptom and the behavior more efficiently. And also, we know what brain areas we need to target. Now, this is a 16-year-old girl with suicidal ideation. She was brought to me because the mom was going through her room and opened one of the drawers on the nightstand and found a suicide note. So she had already written a suicide note. And so she was urgently brought for a brain map. And upon doing the brain map, we can see, if you look at the left temporal lobe, we can see this sharp transient. And it's got field and phase. We have the same transient coming over the left insular region. So here we have some sharp activity. We referred to a neurologist. The neurologist was in agreement that this was indeed a sharp transient, paroxysmal epileptiform-like, and now we saw the region that was compromised. This girl was on Ritalin for ADHD and was on antidepressants. None of those were working. So upon seeing this, my suggestion was to refer to the neurologist. The neurologist referred back to the girl's psychiatrist. I did an interconsult with the psychiatrist. I showed her the EEG. I explained the EEG, and I said, the neurologist feels that she's going to respond better to an anticonvulsant. And based on the brain region, this is the anticonvulsant that we're going to suggest for her. And the psychiatrist, thankfully, was open-minded enough to agree and prescribe said medication, to which the girl responded well. A few weeks after being under the anticonvulsant, the suicidal ideation disappeared. The depression disappeared. So we're seeing that the left insular region was getting the impact from those transients. And this is iMedicine's analytics. We can see the depth and the exact location of the generator, the frequency at which it presents itself. And that helps us reinforce what we're observing out of the clean EEG through the QEEG. And we can now present this to teachers, parents, doctors, and this girl's life was saved because we exactly knew where in the brain was happening. Now, she can bring a friend of hers, a girl of same age in similar circumstances, and it's likely that the brain regions involved are going to be different. Now, here we also see that she has a very fast and persistent beta pattern over the left temporal region, very close to the posterior insula, which is driving up depressive symptoms, which is driving up anxiety, and hence this pattern was what's elevating her suicidal tendencies. She was experiencing levels of anxiety that she was not able to cope with medication and therapy alone. But we wouldn't have known that. There's no possibility that we would have known that had we not looked at the brain. Now, because I know we need to open some room for questions, I'm going to go through this. This is an aggression case. And what you see here is a paroxysmal epileptiform pattern. It's got some spike and wave content in it. Okay. This is a young girl who was experiencing aggression. We look at the EEG and we can see that the generator for the activity is partly the anterior cingulate, but we have the right insular region, which is highly involved in aggression. She was on antidepressants. She was on Ritalin for ADHD. But upon seeing this, I made the same suggestion. Let's refer you to a neurologist. Let's have the neurologist confirm that what we are seeing here is accurate. And let's talk about the best course of action for you. Again, she's withdrawn from the Ritalin. She's withdrawn from the antidepressant. She's put on an anticonvulsant, and the aggressive behavior starts subsiding. Now, we're going to start what they're going to start, because this is a case out of Thailand. They're going to start doing neurofeedback, and now we can target the specific location. So we can do some CZ to T4 training to target that paroxysm and start stabilizing that brain region to hopefully mitigate. Now, once we've done some training, we re-record the EEG periodically to assess and tweak. This is another aggression case. Another female, similar age, but here, what's interesting is that it's not epileptiform. There's no epileptiform paroxysmal content. She has two very active temporal lobes. If you look at T7 and T8, the left temporal lobe is a very persistent and very fast beta pattern. There's beta present in other areas of the brain. There's some slowing in the frontal cortex. There's some slowing in the background in the parietal regions. But what caught my attention as I was recording this is how fast this is. And if you look at the maps here, there's excess data. This is the iMedicine, the Korean database. So this is the comparison maps. And you can see that in the 4 to her 8, in the theta and alpha range, she's making more than the neurotypical cohorts. But you can also pick up the excess beta 2 and beta 3. And you can see it more clearly here in the absolute power distribution maps. The left is active, the right a little more. And if you go back to the EEG, you can see that the persistence and the amplitude, the power for the beta frequencies is a little higher on the right temporal lobe. But we can work on those. This is the source of the aggression. Brain that's getting tired, but two temporal lobes that are extremely. And here you can see the 3D renderings for this case. This is the beta rendering. And look at that frontotemporal region with the beta 2, beta 3. You can also see the connectivity map that shows low connectivity. And as we saw in one of the slides, they talked about either poor connectivity or hyperconnectivity. Here we can see this low connectivity. The temporal lobes are not talking to each other. And because they're not talking to each other, they're not regulating the activity. And you can see, again, the 3D renderings for the beta 3, the connectivity maps as they are extracted from that EEG. And so with that, we can do neurofeedback. So when we do neurofeedback, we're training the brain. And I want to show you here a case that I worked with a while ago. This is a 14-year-old diagnosed with Asperger's, OCD, and suicidal ideation. His OCD was the main thing, and you can see the excess data over at FZ. This is at baseline, and this is 40 sessions of neurofeedback. We ended up doing a total of 120 sessions, if I remember correctly. But you can see the transformation in the brain. And his main thing was that he could not eat with his fingers, or he could not watch people eating with their hands because that would induce vomiting. He would get nauseous and vomit. And after 40 sessions, he started eating chips with his own hands, and he was able to watch people eat with their hands without being grossed at. And obviously, there was a transformation in socioaffective components. The suicidal ideation disappeared. He cursed a lot. When I started working with him, the F-bomb was thrown every third word. And then he stopped cursing altogether, was very aggressive with the mom, stopped being aggressive. And mind you, this is a child, the parents are American from the US, but he was adopted from a Russian orphanage. And he knows he's adopted. He presented with a lot of activity. So this is to illustrate, because I know we're running out of time.
I have a couple of questions if you do allow time.
Yes. We have all the time we need, sorry. So to close here, we need to look at the brain, as you saw several cases. And we can see the value of training the brain with neurofeedback. We can transform lives, but more importantly, we can have more comprehensive assessments that can drive the ability to work holistically. I always refer clients to the nutritionist. Every client that gets a QEEG with me gets referred to the the nutritionist. And most of them will have some kind of metabolic dysregulation that we do. So having said that, thank you so much. I know that I always go over time. It's so hard to plan for these things. Too little info, too much info, but thank you for your attention. And
Thanks, Santiago. Well, you go over time because you have lots of good things to say. So wonderful presentation. There, I I already told people that you're very generous. Will you be able to share your slides?
yes,
Okay.
that would be fun.
Okay, we'll take care of that. That'll get posted. And then going way back to the beginning, in the medical field, when we talk about non-invasive, we talk about anything that doesn't break the skin. But things like TD, TCDS or TMS do send impulses, even though they're not breaking the skin. And, but they're called non-invasive in the medical world. What do you think about like our need to differentiate that when we're addressing that with people? And
Oh,
do you
that's
think
very important. Yeah, I appreciate that someone's bringing that up. What I will say is, if I'm talking about TDCS, TMS, I will say that they're partly invasive in that your brain will receive some kind of controlled impulse, and I will explain to them how it's done, so to appease them. Normally, I would refer to photobiomodulation and the neurofeedback and even the biofeedback too as non-invasive, meaning there's nothing going into the brain. We're only collecting info and using that information to provide the feedback and the training. But if it is something like TDCS or TMS, where the client will experience some degree, have some degree of sensation, then I will explain, yeah, this is partially invasive, but it's done in this way and it's safe for this reason.
And then there's a question about, learning more, like on the data collection. Can you guide us to how would you work with an extremely hyperactive child on collecting their EEG? And just generally, how do you learn more about the QEEG training? What would you suggest?
Well,
God.
so my take on that is, normally with some children, you will not be able to gather eyes closed information, eyes closed EEG. And that's a shame, but it's something we have to deal with. When I work with children, I normally reserve about 2 to 2.5 hours for the session because I know that even though it's only a 5 to 10 minute recording, I'm gonna end up spending the 2 hours. The most important thing is once you start collecting, any system would any good system will allow you to do pause and then resume. So what I will do is I will have the child sit there. Sometimes I have them sit on mommy's lap and mommy's with them and she's talking to them and helping them relax, which helps. I will record. If I get 10 seconds and the kid starts moving, I pause the record. I let the kid move and burn some energy. They can settle down again. I resume the recording. And I will do that until I get at least 5 minutes, hopefully 10 minutes of good data. In my experience, by the time we're collecting 3 to 4 minutes, the kids being it's so tired because they're frustrated that they will wear themselves out and they will sit there quiet. So again, if the kid is can sit there, we record. If they can not sit there and it's not an extreme agitation, I'll have them watch a movie. Again, it's not the ideal scenario, but at least I'll get some clean data. And I'll move around the data and I will take into account that they were watching movie and therefore the brain activity might be a little different. Now, in my personal experience, irrespective of the kid watching a movie, I will see the patterns that I think correlate with the specific symptoms and behaviors. Now, normally, if the child comes to the session, they cannot tolerate the cap. What I will say to the parents is, okay, let's not record anything today. I'm gonna give you this cap. Go home, put it on him. Once he can tolerate it and play and move around with it, then come back and we'll do the QEEG. So the same for either the clips that you put on the mastoids or the ones you clip on the earlobes. I'll have the parents do that. When I start the neurofeedback, I will say, take these couple of electrodes, get the paste, put it on the child. If he's not trying to eat it, then he won't mind it anymore. And you need to be extremely patient. You cannot expect to get an hour of your time and record a clean EEG. If you're working with children, who are agitated, save 2 hours for the session and be very, very patient.
It does take patience, yes. Uh, we've all, like, come up with little skills, little tricks. Thank you for sharing yours. So that just wraps us up perfectly. The recording will be available. You can listen to it all over again. There's a lot in there, and, thank you all for joining. Any final words, Santiago? We appreciate you, and biomedical.
Thank you so much. Good to see you. And have a good night over there and a good day over here on this side of the world. I'll see you guys soon.
Good night,
Okay.
everybody. Thank you.
Bye bye.